Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. My name's Jim Scott and I'm President and CEO of Applied Policy, a health policy and consulting firm based in Alexandria, Virginia. My colleagues and I host these gatherings every month to explore issues shaping 21st century American healthcare. It's been almost 15 years since President Obama signed the Affordable Care Act into law. During that time, the health plan has been subject to multiple changes, both legal and multiple challenges, both legal and political. But as of this year, more than 21 million people are insured through ACA marketplace coverage. Today, we're welcoming two panelists who are now and have been central to shaping and implementing the Affordable Care Act. Jeff Wu is Deputy Director for Policy for the CMS Center for Consumer Information and Insurance Oversight. The center is responsible for regulating and overseeing the ACA marketplaces and ensuring the insurance plans comply with the ACA requirements. Chris Haltmeyer is Vice President of Policy Analysis for the Blue Cross Blue Shield Association, which has played an important role in shaping ACA legislation. Currently, many Blue Cross plans participate in the health insurance exchanges, often as the primary or only health insurance option in some regions of the country. Welcome to you both. Jeff, in your current position, what responsibilities do you have for with respect to the Affordable Care Act?
Well, first of all, Jim, thanks so much to you and the Northern Virginia Health Policy Forum for inviting me to come speak for a bit about one of my favorite topics, the Affordable Care Act and the exchanges. As you noted, I'm the Deputy Director for Policy at a part of CMS called CISIO, which essentially means that I help write the rules for the exchanges, sometimes called marketplaces, and for market-wide insurance coverage. So rules like preventive services and the like, mental health parity also come through CISIO as well as the other departments. So I have a sort of broad policy regulatory role. I guess I'd say that so as part of this, we do everything from I lead a team that does everything from rulemaking to issuing guidance to enforcing those rules to dealing with stakeholders like the Blues plans, which are very significant partners of ours in many of these markets, and really working to make sure that these markets are working well, that consumers are getting access to great affordable coverage. I look back at the last, I guess now it is 14 years, and all of the evolution that has happened. And over that time, with the very active partnership of insurance companies all over this country, we've built some thriving marketplaces in every state in the country. A good number of those states, 19, have opted to set up their own exchanges. And we work very closely with them to do so. And each year, a couple more states think about it. But in all of the other states, we continue to operate the exchange. But these markets have become incredibly vibrant and competitive. As you sort of hinted at, these markets have seen a lot of challenges over the years. There have been some ups and downs. Some of those have been legislative, some of those have been related to litigation, some of them have been sort of very political, healthcare, or many aspects of healthcare. Unfortunately, in this country, sort of swing a little bit on the axes of politics. But through all that, if you look at the through line, it's been really incredible. As you said, more than 20 million people covered today across all of these markets, and these are people who 15 years ago. Many of whom would not have been able to access insurance because they would have been, their conditions would not have been covered, or they would have been deemed uncoverable. And these folks can now participate in this, this vibrant, active market where insurance companies are really, they're fighting like cats and dogs to offer great coverage to these folks. So I'm really happy with where these markets have gone.
Thanks, Jeff. Chris, can you tell us a little bit about your role at Blue Cross Blue Shield and your sort of role in the Affordable Care Act implementation and enrollment?
Sure. And Jim, thanks so much for inviting me to present today. So I've been with the Blues now for 30 years, worked on pretty much every healthcare reform piece of legislation and its implementation. But for half of my career, I've been working with Jeff and folks from the other federal departments on implementation of this law. So it's been a pretty big part of my career. In my role, I represent the individual Blue Cross and Blue Shield plans. There are 33 across the country. They play a pretty significant role on the marketplaces, as you mentioned. Our members offer products that are available to 99% of Americans today across every state. And we cover 8.6 million people on the marketplace. And in addition, 11.6 million people under the Medicaid program, which was also a pretty significant component of the Affordable Care Act. I definitely second what Jeff said about the the stability of the marketplaces today. I do think they're reaching a level of maturity. When this law first started out, it was a very challenging environment for health plans because of some of those changes that Jeff mentioned. Health plans lost a lot of money early on, but we are seeing a lot more robust competition on the marketplace today. And in addition to just the growth in membership, which has really been phenomenal over the past few years, we're seeing rates of premium growth that are lower over the last 4 years than general inflation. So that's just an indicator of how the marketplaces are stabilizing and healthier today than they have been at some periods in the past. You might think it's kind of strange for kind of a dominant player on the exchanges to say we welcome that competition, but I really do think it's evidence that the market is stabilizing. Just one final point about the growth we've seen over the last few years. The marketplaces are really an important source of coverage for people who don't have traditional health insurance through an employer or coverage on the Medicaid program. Jeff, I hope I'm not stealing your thunder on this, but the Treasury Department just released a report that said 50 million Americans have relied on the marketplaces since 2014. And in no point has that reliance been greater than the last few years, where we had the pandemic and then Medicaid unwinding. The marketplaces really have been a critical source of coverage for people during those significant crises in our country. And we're coming up on a major battle here, which will be whether the enhanced tax credits that were available to consumers since early on in the pandemic will be extended. And it's certainly our hope that that is something that Congress does so that these marketplaces remain strong and stable.
Thanks, Chris. I'm going to come back to those tax credits in a few minutes, but Jeff, could you please give us sort of Affordable Care Act Marketplace Exchange 101 lesson so that all of our audience can follow some of the jargon like essential health benefits and all those other terms that we might be using later on today?
Sure, Jim. Absolutely happy to do that. Before I do that, thanks, Chris, for mentioning the 50 million Americans covered since the inception of the ACA in the marketplaces. That was absolutely a huge statistic, and really goes to, and I really share Chris's view here, underline how fundamental the marketplaces are to commercial coverage. I think this is a theme that I'll be coming back to a couple of times in this discussion, but I view the marketplaces as the backbone essentially of commercial coverage. It does not encompass the majority of coverage. That continues to be sort of group health plans and employment that folks get through coverage that folks get through employment, but But when folks are between jobs, when folks are starting off on their own, when you know, in all of those sorts of situations, the marketplaces are there as a backstop, and you know, and I think they are in ways more and more common. They are becoming you know, a key economic tool for the vibrancy of our economy, because folks know that they can move jobs, they can leave their jobs, they can start their own businesses, and you know, and find coverage. So anyway, sorry, that was a bit of a detour. I'm sure we'll come back to those points. Let me talk just a little bit about how these marketplaces work. And Jim, you had said at the beginning, sort of like exchanges, marketplaces. So let me just start with that. The Affordable Care Act provides that every state will have what's called a health insurance exchange. We call them exchanges. We call them marketplaces. They are the same thing. And that is, you can just think of it as a website in which any consumer can go and purchase coverage. The website itself will allow the consumer to go through all of the eligibility determination processes needed to figure out if they can purchase this coverage, as well as eligibility for tax credits. So health insurance is expensive. We are often shielded from the expense, you know, the raw numbers for those of us who have employer-based coverage, because our employers often pick up a hefty chunk of it. But you know, and there are tax advantages to it and all of that. But health insurance is expensive because the cost of healthcare in America is expensive. In the exchanges, the marketplaces offer financial assistance, essentially, both for premiums, you know, payment of premiums, as well as in many cases for lots of people, for cost sharing, by which I mean sort of like lower deductibles, lower copays, those sorts of things. So there's a lot of financial assistance available for lots of people through these websites. The coverage that is offered on these websites has to meet certain standards set up by the Affordable Care Act. Those standards include the benefits that are covered, and Jim, you mentioned the 10 essential health benefits. So the ACA sets out these 10 broad buckets of benefits that have to be covered by these plans. Every state sets forth a benchmark as to sort of what that really means. The net result of that is all the plans that are offered through these exchanges, they're good plans. They offer strong, comprehensive benefits. They are what we call comprehensive medical coverage. And they cover all the things that one would normally expect a plan to cover. And they have to meet other standards required by the Affordable Care Act around adequacy of networks, around certain essential community providers. There's lots of aspects of these plans that are governed to make sure that that the plans that you get through going to these websites and picking them are good coverage, and also that there's a level playing field, that all the insurers that come to this place and offer their coverage are sort of like, you know, not able to undercut each other by offering poor quality plans. That is essentially how it works. There's a lot of complexity to the determination of eligibility, to sort of figuring out how much financial assistance you get. But I will flag that this financial assistance, which you know we have been loosely calling premium tax credits, is you know, for lots of folks, depending on your income level, very, very significant. And for folks of income ranges where their household income level is, say, no more than 150% of federal poverty level, and there's lots of folks in those buckets, they can find free coverage. Free coverage that is very high quality coverage. So hopefully that's helpful in terms of the mechanics of how this system works. And then once you purchase that coverage, then it is just like you had any sort of other form of commercial health coverage. You have a contractual relationship with that health carrier, whether it be a Blues plan or or some other plan, and you as the enrollee are then you can avail yourself of the full set of services and customer supports and the like that health insurance carrier provides.
Thanks, Jeff. And on the premium tax credits, how do people find out if they're eligible for a full subsidy or a partial subsidy?
So when you go to these marketplaces, and I should also note here that in terms of the ways that you can get to these plans, there's a number of ways. You can go to the website, which lots of people do. You can call the call center, and a person on the other end will help walk you through the process. The purchase of health insurance is often complicated, and sometimes it helps to have someone help you through it. And then there's this huge channel of navigators who are sort of community funded and funded by the federal government or the exchange entities that will help you do this, or agents and brokers, which is by far the biggest channel for this. Agents and brokers across the country will help people find the coverage that that is best for them. But as part of that process, no matter which of these channels you go through, you will go through a sort of a financial determination process. It's a little bit like, I mean, this is high in my mind now because I've got another kid headed to college, but like, it's like filling out the FAFSA. You fess up on like the amount of income you're likely to make and all these sorts of things from all of your various sources. And there's, written into the Internal Revenue Code, there's a table that says how much financial assistance you can get based on your income. And it's a function of your income and the cost of a plan. The way this financial assistance is structured is, even if plans over time get more expensive, and we all know that there are lots of challenges in the healthcare system due to costs. These are sometimes the fact that we're paying for very near miraculous therapies, but you can imagine things like gene therapies and the like coming in, and people worry about the cost of care. But the genius of the financial structure of this financial assistance is that the financial assistance goes up even if the cost of healthcare and coverage goes up. But essentially, you go through this process where you answer a bunch of questions, often with the help of someone, and then you can figure out exactly how much you can get in advance. And then at the end of the tax year, so you finish that year, when it comes time to file your taxes, there's a reconciliation that happens. You write down essentially how much financial assistance you got each month, and then they look at your taxable income and they compare it to to that table, and they say, oh, actually it turns out that you claimed a little bit too much, or you didn't claim enough, and then you get a refund or have to pay in more in taxes. But there's a reconciliation at the end, because a lot of the stuff at the beginning of the year, sometimes it's estimation, sometimes folks do better or worse during the year in terms of their financial results.
Thanks, Jeff. And Chris, if I'm understanding the program correctly, the amount of assistance is based on the second lowest cost silver plan. And then can you tell us a little bit about the metal levels and what the difference between the metal levels are, and then we'll get back to the premium assistance?
Yeah, this gets a little complicated, but you're right. The actual premium subsidy level is set based on what's essentially a competitive bidding program that's tied to the second lowest cost silver plan. So if you are at that premium level, you will pay no more. But if you choose a plan that is more expensive than that second lowest cost silver plan in any area, then you do have to pay additional amounts for your coverage. The metal levels are, so there are metal levels like bronze, silver, gold on the exchanges. They were really designed to help people understand how much cost sharing protection they would get in any given plan. So they have what are called actuarial values attached to them. We don't need to go into that, but essentially, if you're choosing a bronze plan, you'll get less protection generally than if you're choosing a silver plan. And for people who enroll in silver plans, they get additional protection called cost sharing reductions. So for people who are lower income, need that protection, it's important to consider the silver plans in that scenario.
Thank you. And then, Jeff, so with premium tax credit, I think you determine your eligibility when you go to the marketplace, then you find out how much premium assistance you get relative to the second lowest cost silver plan. You can pick any plan you want. Do you have to pay that premium up front and then it gets refunded by the IRS at the end of the year? Or is the credit in advance? So if you're eligible for a free plan, you don't have to use your own money. You just have to pick a plan.
Indeed, the credit is advanced. It doesn't go to you, the consumer. It goes directly
Can you
to
explain that a little bit?
Yeah, it goes. Sure, it doesn't. The credit is advanced. It doesn't go to you directly, the consumer. It goes to the insurance company, and the insurance company will only bill you for the difference. But that way, the consumer isn't asked to front this very large premium all year and then wait for tax time to get reimbursed. Now, you have the discretion as a consumer, if you want to take less financial assistance, because in the end, as I said, all of this gets reconciled at tax time. So after the end of the year, when you're filing your taxes, the proper amount of tax credits gets calculated, and there's whatever back and forth that needs to happen between you and the IRS to work that through. But as a matter of cash flow, the estimated amount of financial assistance that you are determined eligible for in that initial process, you can get that applied every month to your premium, so that you are not stuck with carrying this bill throughout the year.
And if I could just add, I think that's really a critical point in how these tax credits operate. About 2/3 of people buying on the marketplaces have individual income of less than $40,000 a year. So being able to get that tax credit up front when they're purchasing coverage, rather than waiting till they file their taxes, is critical to enabling them to buy coverage.
Thanks. And Chris, you can probably answer this. If I pick a plan, I get my premium for the silver level. I get help paying that. If I pick a bronze plan that's less expensive, do I get the difference refunded to me at the end of the year, or do I only get the premium assistance for the plan I picked?
Now, premium assistance is available for different metal level plans, but the amount of subsidy or tax credit you get will really depend on the plan you choose. So you might be able to get a free bronze plan, in many areas, or you might find that it's a better deal to buy a silver plan, or you could buy a gold plan. You'll still get some assistance. It's just less assistance than typically the bronze or silver plan.
So I can't pick a cheaper plan and then get the excess premium assistance refunded to me.
No, sorry, no,
evaporates.
You can't do that. No.
You can't make money off the transaction that way. The amount of financial assistance is capped at the premium of the plan that you pick.
Right.
But nice try.
Thanks for that. And then it's my understanding that at the end of 2025, something with respect to the premium tax credits expires, and that'll affect some people who get assistance. Chris, could you unpack that for us?
Yeah, so during the pandemic, there was an enhanced tax credit that was enacted, which provided additional protection really for everybody buying on the exchange. So Jeff mentioned that some of that assistance was really targeted towards the lowest income people making less than 150% of the poverty level. But it also extended some protection to people over 400% of the poverty level. So it really, I think, addressed some weaknesses in the original design of the tax credits under the ACA. If those enhanced tax credits expire, everybody on the marketplace who's eligible for tax credit will see a premium increase. The level of premium increase, could be as high or is likely to be on average more than $1,000 in 2026. So if Congress doesn't act by the end of 2025, and really I think that should be, Congress should act much earlier than that, and we can talk about why that's so, people will be exposed to those higher premium costs, and they'll actually be exposed to those beginning during open enrollment, in the fall of 2025. So there's a need for Congress to act pretty quickly next year to extend those enhanced premium tax credits. If Congress doesn't act to do that, I think you'll see some pretty significant impacts on the marketplace. Based on some of the public estimates that have already been released, more than 5 million people could lose their health insurance coverage. We have to remember, this is a marketplace that is really serving a lot of people with significant health conditions. And a lot of those people who go uninsured will be people who have significant health conditions who just can't make that premium payment.
Thanks. So if I'm understanding correctly, nothing will change for people who make less than 400% of the poverty line. What they're really talking about extending is the assistance for people at 400 or above. But overall, you're saying if that disappears, the premiums are going to go up for everybody across the board. Did I get that right?
No, I mean, you are right that if you have that many people leave the market, average premiums will increase for everyone. But the enhanced tax credits actually lowered the amount people pay for their premium across the board. And so if you look at the growth we've seen on the marketplaces since 2022, the marketplaces have grown by 88% during that period. The place where they've actually grown the most are in states that haven't expanded Medicaid. So think about, Texas, 212% growth. Alabama, 190% growth. So a lot of these more conservative states that haven't expanded Medicaid have seen significant growth, in part because those tax credits were enhanced for that lower income population that otherwise wouldn't be able to afford coverage.
Thanks, Chris. And Jeff, since we're talking a little bit about the states that haven't expanded Medicaid, it's been a while since I looked at this, but there was a problem, and I was going to ask you if it still exists, with people who don't qualify for Medicaid in their state program, but they're also low income, but they don't qualify for premium assistance and fall in sort of a gap. Does that still exist anywhere? And is anything being done to address that?
That does still exist. The way the statutes have been set up under the Affordable Care Act, in these marketplaces, premium assistance is available down to 100% of the federal poverty level. And I think the assumption at the time, the drafting of the statute, was that Medicaid expansion would occur very broadly, and you would you would not find this gap. But of course, as Chris has mentioned, not every state has expanded Medicaid, and for many of those states, the Medicaid income eligibility levels don't reach all the way up to 100% for all populations, and so you will find people who don't qualify for state Medicaid, but do not have sufficient income. In other words, do not reach 100% of the federal poverty level for their household income, qualify for tax credits in the marketplaces. So that continues to be a real challenge. There's a lot of folks there who end up getting their care through going to the emergency room when they are in crisis. It's a very bad way to manage your care. I will note that, and I think this builds on the point that Chris was making. If these enhanced tax credits do expire, as Chris points out, what happens is this coverage becomes a lot less affordable for a lot of people, and we can expect that a very significant number of them might choose not to continue their coverage. That itself, will end up raising premiums for those who stay, which can feed this negative loop where, as the premiums go up, more people say, "Oh, I don't know if I, am willing to pay for that." And then what happens is hospital systems often get stuck with a lot of care that they can't get reimbursed for. So this ends up being, yet another financial stressor on hospital systems as well. So I do notice, and I have noticed that in fact, trade groups like the American Hospital Association and the AMA, so the physicians out there, I mean, a lot of the groups in the healthcare system are really interested in pushing hard for the extension of these enhanced guidelines.
Great, thanks. And Chris, so I was wondering, so since Jeff said that hospitals sort of bear the weight of people without insurance because they show up in the emergency room and they take care of them anyway, is there anything hospitals can do to, when they get an uninsured patient, that needs care, to try to sign them up for health insurance then? Or is it only once a year for open enrollment that you can get coverage? What can they do?
Well, I think hospitals and other healthcare providers are important partners in trying to ensure that everybody maintains health insurance coverage. There are some limitations on, when somebody can enroll on the marketplaces. Generally, it's limited to the open enrollment periods, but there are special enrollment periods when people have, for example, a loss of coverage that they can apply for. That was a important consideration in the drafting of this law to help insurance be affordable. Just-in-time insurance doesn't really work financially. But that being said, we have excellent partners. Jeff mentioned some of them that are with us, trying to ensure that the marketplaces remain stable. Healthcare providers can play an important role in ensuring people sign up when they're eligible to do so, and so that this is an important partnership.
Am I right that for at least once a year during the open enrollment period, a hospital could have a program under which everybody that shows up gets some assistance in choosing a health plan if the barrier was health insurance literacy or anything like that, to show them that they may qualify for premium assistance and they can have insurance? And so the hospitals could at least do that if they wanted to, or is there some reason they can't?
So the Affordable Care Act provides for community organizations called navigators to help get folks into coverage, to help folks figure out what they're eligible for, whether that be Medicaid, whether that be marketplace coverage, that sort of thing. CMS has really invested very aggressively in outreach to folks all over the country, as well as funding navigators all over the country to identify folks who aren't covered and to help them get it into coverage. Many of those navigators are affiliated with hospital systems, who, Jim, as you point out, have a natural incentive to help folks in the community get into coverage that they are eligible for. And we do think that many of those navigators are very successful. They have connections with these communities, and they have connections with these folks, and they can work with them to get into coverage. We know that some of these hospital systems, they're very aware that and they are carrying the load on subpopulations of very sick patients that and they know when they're not covered, and so we know that many of them work very actively to throughout the year try to get them into coverage. whether that be Medicaid or, Marketplace or whatever else they might be eligible for.
Thanks, Jeff. We've identified one group, those folks in expansion states that don't qualify for Medicaid and also don't qualify for premium assistance, that have limited means. So I understand why they might still be uninsured. Who else is uninsured, and has CMS looked at the reasons that they don't have insurance to try to reach them?
No, absolutely. And as we have been discussing, we have been on a really successful run in terms of increasing enrollment in the marketplaces and driving down the rates of the uninsured in this country. There's still lots of people out there who do not have coverage. Not everyone is eligible for marketplace coverage. I mean, we talked a little bit about folks who might not be eligible for the financial assistance, but one of the big factors for eligibility for marketplace coverage is that as a legal matter, you have to be lawfully present in the country. And that's in the statute. And so there are subpopulations of folks in this country who are not eligible for exchange coverage because of that. And there are lots of rules about the exact sorts of immigration statuses that are eligible and not eligible. So I will say, right off the top, there are certain populations that we cannot reach through these. There are many states that have separate programs for those folks. But then I also think there are lots of people out there who, for whatever reason, I mean, there are people who, I was a young man once, and I thought that I would never need to go to the hospital or see a doctor because I just didn't think that would happen to me. There are lots of people like that who don't feel that they need the coverage, often, unfortunately, until it's too late. There are lots of folks who just aren't fully aware, and there's lots of people in this country, and particularly in particular language groups and the like, where we continue to work really hard to get the word out. We have been, as I said, investing very hard in navigator groups that we think will have a better shot at penetrating, ethnic subpopulations and the like, and to get the word out. I think there's still like a pretty substantial addressable market of folks who are eligible for this health coverage that we're leaving no stone unturned in trying to get to.
Thanks, Jeff. Chris, from your perspective, do you agree with those buckets of folks who don't have insurance? And is there any angle that Blue Cross Blue Shield is looking at to try to get people who don't have insurance so they do have insurance?
Yeah, and just want to recognize too that we are at a historically low rate of uninsurance in this country. In part, that's because of the changes that have been made, over the last 15 years and all the outreach efforts that have been occurring here. I think I mean, to Jeff's point about just the interest in insurance coverage, I think he identified all the right groups there. But it is challenging to get people to buy insurance when they, before they need it, right? It's not the sexiest product in the world, right? But when you need it, you need it. So, I think one thing that our members have been doing is really, going out and trying to make it easier for people to come in and learn about insurance. A lot of them are offering, retail centers now where someone can walk in to a shopping center and learn about the products that are offered and connect one-on-one. When they have challenges with their coverage, they can go in and get help. And so that trying to reach people where they are, in addition to all the work that CMS has been doing in terms of outreach with other parties, we think is a pretty important strategy.
Thank you, Jeff. Reducing healthcare disparities has been a big priority of CMS. Have you seen any disparities into access to health insurance under the exchanges, both with what kinds of coverage people are able to get and those that don't have any coverage at all? And has CMS been doing anything proactively to address those disparities?
Absolutely, Tim, and I'm really glad you asked this question. In this administration, there's been a big focus on health disparities and health equity generally. The avenue I think that societal has been really leaning hard into this area is looking hard at trying to beat disparities in coverage. And we've talked a little bit about this already, but we have seen significant disparities in by ethnicity and race, for example, in terms of who we're reaching and getting to sign up for coverage. Some of this gets very tricky, for example, in say in Hispanic communities, where you have families that that have mixed status in terms of documentation and the like. So some of the folks in the family might be eligible for for marketplace coverage or for other Medicaid or other forms of coverage. But some in the family might not be, and we think often in these families there's a significant reluctance to engage with these kinds of federal programs, with providing the sorts of information that are required to be provided to determine eligibility and the like. And so we have been working very hard in those communities and funding community organizations and trying to get outreach out in those languages to try to allay some of those fears, to try to get people to understand that that none of this can be used for enforcement purposes. That in everyone's interest for those who are eligible to get them into coverage. But for sure, there are lots of challenges on this front. Unfortunately, as with sort of almost everything relating to health disparities and health equities, it's always sort of the same patterns that you see, on every front, whether it's sort of like who's covered, who gets the care, how good the care is, and the like. And there's no exception here. But I will say that the way that society has been trying to lean hard into this is really focusing on coverage and getting the messaging out, because in the end, like I say, nothing is perfect, and our coverage isn't perfect either. But fundamentally, this is good affordable coverage, and we think that making a good product available and getting the word out is gonna lead to good results.
Chris, is addressing healthcare disparities and improving health equity also important to Blue Cross Blue Shield, or is that just a CMS thing?
No, it's fundamentally important to us. It's one of our strategic pillars as an organization. We've been focusing a lot on maternal morbidity and mortality. If you want to learn about what the Blue Cross Blue Shield companies are doing, go to our website. There's a lot of information on that. We're also very supportive of the work that CMS has been doing to address health disparities and some of the initiatives that have come out of the administration to help collect the data that's needed to ensure that we can measure progress in this area. And just on the marketplace, again, I think it's important to note that 61% of the people who've gained coverage since 2020 are communities of color or people of color. And those are the people that will be most at risk if these enhanced tax credits are not extended.
Thanks, Chris. And let me change the subject a little bit. So employer-sponsored coverage, if the employer doesn't offer coverage, then their employees are eligible for enrollment on the exchanges. I also heard about a small business, like I think it's called the Shop Exchange. So as an employer, should all good employers still offer health insurance as one of the key benefits to their employees? Or should they look to the Shop Exchange, or should they just sort of give all their employees a little bit extra money that would cover their premium for whatever they pick on the health insurance exchange. What's the right thing for employers to do, and how should they be thinking about this?
Well, I can start on that one. I think there's a very strong incentive for employers to offer coverage. Certainly today, given how strong the economy is and how low the unemployment rate is. So I'm part of a number of employer organizations in Washington here. I don't see any perspective that major employers won't continue to offer coverage. There's been some commentary recently that the marketplaces could cause erosion of employer coverage. We're not seeing that as well. The rate of employer sponsorship of coverage has stayed pretty constant over time here, and that largely is because for a lot of employees, the tax treatment of coverage in the marketplace isn't as favorable as it actually is for employer-sponsored coverage. So for higher wage employees, they would actually pay more on the marketplace than they would typically in the employer coverage. And in terms of small employers, I think the marketplace has played a pretty important role for entrepreneurs. And as we think about, some populations that wouldn't be potentially covered under traditional employment-based system, like, gig workers, you could see that playing a more important role in the future. And then we have new types of coverage arrangements, like these are complicated acronyms, but it's the ICRA and QSARA programs, which allow employers to sponsor options where people can get marketplace coverage. So they can select their own plan on the marketplace, but employers still have a role in sponsoring. So I think that's actually an area where we're starting to see more attention and interest, and it could be an area where we see growth in the future for employers that don't have the resources to fund a traditional plan. And I think it's also important to note that those types of arrangements, and the ICRA arrangement was really put in place under the Trump administration, are only viable if you have a strong individual market.
So, Chris, what does ICRA stand for? Is it ICRA?
Yeah, it's individual coverage health reimbursement arrangement. And so Jeff probably knows more than I've ever learned about it, recalls more than I ever learned about it. But it's a way for employers to sponsor a plan, but their employees can go onto the exchange, select their own coverage. For smaller employers, it is harder to offer a choice of products. And so, that is for a small employer that's looking for that type of choice, when they're competing for talent in the marketplace, this is something to consider. And they are starting to become more common in more states here as well.
Thanks, Jeff. Do the shop exchanges still exist, and where are those, and are people using them? Can you tell us a little bit about that?
Yeah, sure. So the shop exchanges, which are essentially exchanges for small businesses, I think they still, I guess you could say, they still technically exist. As a functional matter, they exist sort of in theory. As a functional matter, if you are a small business and you are looking to buy a small group plan, the plans in your state are regulated by the Affordable Care Act. They have to be good coverage. They have to cover the 10 essential health benefits. All of these consumer protections that apply in exchange coverage for individuals also apply to small business coverage. But you don't go to the website and do the purchase. You can go through your broker and purchase any small group plan, but it will come with all of these protections and be subject to all of these ACA provisions. As Chris points out, I think there's it is still relatively small, but I think it is growing. Many small businesses are looking to perhaps get out of the business of administering a group health plan themselves, and perhaps just sponsor coverage by providing an amount of money under the ICRA to allow their employees to just go onto the exchange and purchase coverage, purchase the coverage that's right for them, instead of having the boss of the company, pick the kind of coverage that everyone in the company has to get, especially as Chris points out with a small company. It's hard to offer like a whole slew of options so that everyone can, make sure that they find coverage with the physician that they want or with the hospital system they want, and the like. And so, the rules that we put out, and this is not just CMS rules, but we put out with our colleagues in the Department of Labor, Department of the Treasury, because a lot of stuff is tax related, permit businesses to do this. Not just small businesses, large businesses too, but I think more of the take up has been on the small business side.
Thanks. Let's sort of, we're running out of time, but I'd like to look towards the future. Jeff, does CMS have, I know at Applied Policy, we work on Medicare a lot, and we're very used to, the physician fee schedule rule coming out in July, and the hospital inpatient rule coming out in spring. Is there do the exchanges administratively run the same way? Is there an annual rulemaking cycle? And if so, about what time should we expect the new proposed rule?
So thanks, Jim. I laugh because this is the same question that I get at so many meetings that I sit in with Chris on. There is indeed an annual cycle for rulemaking. It's not nearly as involved as say it is for fee-for-service Medicare, where there's a whole slew of rules that they put out with reimbursement rates and the like, subject to very complicated statutory adjustments and like. Society puts out one rule each year that is focused on exchanges. We call it the payment notice. It tends to come out in the fall and finalize sort of in the winter. And that sets, it is not so much a rule that providers look towards the way they do, obviously, for fee-for-service Medicare. It tends to be a rule much more focused on insurance companies and what the parameters will be, what the payment parameters will be, what any tweaks to benefits, any tweaks to network requirements, those sorts of things. But that's an important rule for marketplaces and for the industry. And Chris and I and lots of our compatriots have lots of discussions around those rules each year. Yeah, so for sure, but it's just the one rule, so a little bit easier to track that governs the exchanges. There are rules that come out periodically that are not part of this cycle that cover the commercial market more broadly, that the Department of Labor, Department of Treasury, and CMS put out together. But that's sort of a different cycle, and those are rules, like I said, that affect all commercial.
Thanks, Jeff. I've always loved CMS's seasonal references, and that's the only reason I know winter starts on December 20th and December 19th is still the fall. So we'll keep checking, for that rule. And Chris, I know, the premium tax credits are really important. In our experience, when there's one sort of must-do expiring provision, that seems to attract other changes and is seen as an opportunity to make other changes to the Affordable Care Act. Is there anything that you're tracking or would like to see besides the premium tax credit that we should be paying attention to?
I think that's really the major change that we see, on the horizon here. Whether that's done, by itself or part of a larger package. I don't see in the short term, a lot of appetite for making wholesale changes. But of course, we will have an election in just under 50 days now, I think, and how the results of that election come out, will have a bearing on, how Congress proceeds when they take up tax reform, whether this is part of a broader package or not. So we'll just have to kind of wait and see as to what the outcome of the election is. And but yeah, I don't see it in the short term, at least, much additional, changes that people are talking about.
Thanks. And Chris, if there's one thing that you'd like our audience to take away from our conversation today, what would that one thing be?
Well, I'd hate to say it's those enhanced tax credits. Again, I think I've mentioned them like 4 or 5 times, but yeah, I think, just understanding the importance of this marketplace, the need to extend those tax credits. We didn't talk about some other really critical things like the need to have a robust risk adjustment program, just given how, high risk the population is that's buying in this marketplace. Or some of the efforts that I know CMS is working on to address to ensure program integrity. But yeah, I think that's the key thing, just the important role that this program plays for more than 20 million Americans today, and that the need to really focus on those tax credits.
Thanks. And Jeff, we'll give you the final thought. What should our audience remember about our conversation today from your perspective?
Well, I think I would echo what Chris just said, and say that these marketplaces are really on a really wonderful role. They are vibrant, thriving markets. They are more and more at the core of the commercial coverage market, and also the healthcare system, because of the reliance that hospitals and providers and the like have on reimbursement for all the folks who would otherwise be uncovered. We've made a lot of progress as a society in driving down the uninsured rate over the last 10, 15 years. And this is a huge part of that. I think that's a really important thing to keep in mind.
Thank you both. This brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you, Jeff Wu, for your public service and spending time for us today. And also thank you, Chris, for the work you've done over the past 30 years in the insurance area, and for sharing your insights today about the Affordable Care Act, present and future. We hope you'll all join us for our next forum on October 22nd, when we take an in-depth look at the current status and potential impacts of CMS's drug price negotiation program. Before I close, we just sent a message in the chat with links to subscribe to our monthly newsletter and view our Northern Virginia Health Policy Forum website for more in-depth insights into the reimbursement issues and current health policy. Thank you all for being here. Thank you to the Applied Policy team for making this possible, and enjoy the rest of your day.